4, 3, 2, 1. Sir, we are live now.
Okay, good evening, everybody. Welcome to today's webinar brought to you by the Orthopedic Research and Education Foundation, India. Today, we have the pleasure of having Dr. Vikas Agashe from Hinduja Hospital, Bombay. And basically, he will be discussing some interesting cases, which is to be an interactive session. So without much ado, over to you, Vikas.
Good evening, friends. We will have an interactive session. So I request you all to switch on your videos and audios.
Yes, sir. So probably few of them are joining now.
Acha, okay. So we should wait.
No, sir. Can continue.
So interactive कैसे करेंगे?
सर कोई इंट्रोडक्शन वाला स्लाइड कर लीजिए तो
नहीं, इंट्रोडक्शन वाला तो स्लाइड नहीं है.
We'll interact amongst ourselves.
I think so. तो Thursday मिलेंगे, John?
Yeah, I will try. Actually, I'm in Guwahati. And I am not sure exactly. Hopefully, I'll be free by then, but can't be 100% sure.
Acha. So you're gone for a visit or
Yeah.
Vacation or?
No, work involved.
Acha, work involved. Okay. So
Maybe
the conference is there till Thursday.
No, this is not a conference. This is something.
Acha, okay, some other work. Okay.
So, Janki, what's happening?
it's joining, sir. Maybe because of change in time.
So 9th, 10th February, you said, na?
What is 10th and 11th of February? 10th is the main
CME.
CME.
Okay.
Yes, sir.
Okay.
Subhansu has joined. Yes, Subhansu, inform everyone.
Tuesday happens to be my theatre day. So
No.
7 becomes little odd.
Okay.
So there will be a CME on infections.
Yeah.
Okay.
CME is going to be of 1.5 or 2 hours on.
Okay. Okay.
It will include. So I think basically we should go through the gamut of things from diagnosis to treatment and prevention also.
Okay. Okay.
So if you have a microbiologist,
Yes.
that'll be good, and then probably involve Bobby John from Ludhiana and myself and maybe one more local faculty.
So they have joined, 2 persons have joined and they are still joining. So Subhansu is there. Rajan has joined already.
So we can get started, I think.
Yes, sir, we can start. Subhansu Pratyush.
Okay.
Yeah.
Yes, sir. Achha.
Very good.
Keep your audio and video on. Yes, sir.
Sumanshu, please
Yes,
put
sir.
on the video.
Good evening, sir. Yes, sir.
Yes. Since you have joined first, let's start with this case.
10-month-old.
This young boy, 15 months only. has a discharging sinus for 2 months. Okay,
Yes,
so I'll just run through the history. That's the proximal humerus lytic area. That is what he had. So tracing the history, he had shoulder pain, many difficulty in moving the shoulder. X-ray and MRI were suggestive of lytic lesions. So he was sent to an oncosurgeon and image-guided biopsy was done.
yes,
Shows granuloma, gene expert positive, rifampicin resistance not detected. Started
Yes,
on first line 4-drug ATT by pediatric and at 2 months developed sinus with increasing pain. At 2 months, after starting ATT,
sir.
till then there was no
ATT.
sinus. So after starting ATT,
Yes, sir.
developed sinus. And this is the MRI, which shows the previous MRI is not with me, but it is reported that there is a definite increase in the lesion as compared to previous MRI.
Yes, sir.
Okay,
Yes, sir.
so bolo.
So, sir, it may be said of sensitive to sir. It is a case of atypical microaction.
Okay, Rajan Rai.
Yeah. Rajan and Pratyush, keep your audio and video on.
Okay, so why do you think this is likely to be atypical mycobacteria?
Sir, it is gene expert, sir, positive. So, mycobacterium is there. Matlab, mycobacterium infection is present, but it not responding to, sir, our empirical ATT, sir, anti-tubercular drugs. So the lesion is increasing in nature. So
Okay, Pratyush, what do you think? Subhanshu has said that
Just fine. Sorry.
Yes, Pratyush, we are able to hear you.
Sir, I have just joined, sir. I am not able
okay,
to-
I'll go back. This is a young boy, 15 months only, has a discharging sinus for 2 months. Now, tracing the history, he had an X-ray lytic lesion in the humerus. Okay,
Yes, sir.
X-ray and MRI was suggestive of proximal humerus lytic lesion. Thinking that this could be malignancy, he was sent to an oncosurgeon who did a biopsy, which picked up caseous granuloma. Gene expert was positive, RIF resistance not detected. He was started on first line 4-drug ATT by physician, and after starting ATT, 2 months after starting ATT, he developed sinus with increasing pain. And that's the MRI at present. You can see there is a large lesion going into the physis, right? Going through the epiphyseal plate into the physis. And now what should we do? Shubhanshu feels that this is more likely to be atypical mycobacteria because the gene expert is positive, but is not responding. Am I right, Shubhanshu? Yes, Pratyush.
Yes, sir. This might be, sir, atypical mycobacterium tuberculosis, sir.
Okay. So one thing you remember, atypical mycobacteria are not Mycobacterium tuberculosis, and gene expert is specific for Mycobacterium tuberculosis. So a gene expert positive rules out atypical mycobacterial infections. So you may have a smear which is positive for AFB and gene expert is negative, so that means it is a typical mycobacteria. If gene expert is positive, it is not a typical mycobacteria.
Yes, sir.
So what should I do now? What should I do?
If anyone else have any other view, you can answer.
Okay, if there is no other view, I will go ahead. So obviously, I felt that the burden
Basically-
of infection. Sorry.
I know, I was just going to say that if you've got a lesion that is increasing in spite of treatment, you need to think about debriding and
Correct.
reducing
Right. So I admitted him and decided to debride. You can see that's the incision, and that's the debridement I have done. You can see a big opening there, and I have scraped it. Now, when I referred him to a pediatrician, after he got admitted, I referred him to another pediatrician. And he said he added moxifloxacin and cycloserine. And I was very upset. I was very, very upset that he has started this. Now, any inputs on this? Anyway, I'll tell you something which I learned in this case. So, if the infection is because of Mycobacterium bovis, it is inherently resistant to pyrazinamide. So, the pediatrician said that this is very likely to be a bovis, and the midget came as pyrazinamide resistant. And pyrazinamide is a very important drug. So he continued cycloserine for 1 year, moxiflox and cycloserine. And this bovis is naturally resistant to pyrazinamide. So that is the only reason, generally it is the only reason for pyrazinamide monoresistance. Pyrazinamide monoresistance is not very common. So this is something I learned. Now there's a big lesion here. What should I do? I have scraped it and there's a big hole there. What should I do?
Sir, we can put cement, antibiotic cement, sir.
Okay.
It's a 1-year-old child, did you say?
Uh,
Oh yeah, 15 months. Only 1 year old.
This is 15-year-old, sir.
15 months.
15 months,
Not yet.
15 months. So what would you like to do? You will put antibiotic cement beads.
Sir, we can, draining. Yes, sir.
Okay. What antibiotic will you put?
Sir,
Rajan Rai.
No.
Rajan Rai, would you like to do something?
You can add bone grafts, sir.
Bone graft. Perfect. Why do you want to put bone grafts?
So to fill the cavity, and bone grafts will have other properties.
Like so remember, at 15 months, the bone regeneration and growth
Very
is
quickly.
so good that generally you don't need bone grafting, especially in TB case, because if the medicines are working, there is no problem. He would heal. Okay, so this is at 9 months and this is at 5 years. It's 5 years. You can't even make out that he has had some infection. Barabar?
Yes, sir.
That's the.
Great.
So in case there is a monoresistance to pyrazinamide, remember this could be bovis and you need to add not just one drug, 2 drugs. This is Not my knowledge. This is something my pediatrician friend told me. Okay. Okay, now let's have somebody else. I see Madhusudan, Abhipray.
Yes.
Friends, please keep your video on. Please keep your video on, all of you. Madhusudan Kumar, can you tell me something about this injury? She's a
Madhusudan, just read the
50-year-old.
X-ray. Yeah. I think he's not yet.
Maybe you pass it to someone else.
Yeah.
Yeah.
So, Pratyush, Rajan has not yet answered. So, these two.
So this is X-ray. Ankle X-ray of ankle joint.
Yeah.
PA and lateral view. AP and lateral view. Showing fracture dislocation of the distal fibula or ankle.
So what is the type of fracture of fibula? What do you mean by dislocation? Can you just specify? You're absolutely right. Can you just elaborate a bit? Anyone? Can anyone elaborate on the fracture of the fibula and dislocation?
Sir, it is a Weber type B fracture, sir, with
B.
syndesmotic injury
B
A.
is at what level?
above 5
B.
centimeters, sir.
Above 5 centimeters.
So within joint region is A, till 5 centimeter is B, then
what's-
above
Niche
is,
the-
What's below the joint?
sorry sir,
The joint is C.
no, above the joint is, above is 5 centimeter is C, from joint to till is A, ABC.
So does this, yeah. Sorry.
With calcaneum fracture and syndesmotic injury and ankle joint dislocation with ankle joint dislocation.
Anyone else? So what is the dislocation? Can you just think what structures are likely to be injured?
Anterior, the extensor compartment is more injured, like anterior tibial artery and nerve.
Anterior tibial artery and nerve are likely to be injured. Okay.
Yes, sir.
Anything else? Let me tell you, the sensations were well maintained and the pulse was good. What other structure is likely to be damaged?
Sir, spine, sir, it is 4 feet. So,
No, let's talk of ankle.
acha, okay. Sir, tell us, sir, it is a calcaneum fracture and talus can be injured, sir. Fibular
Talus can be
impingement
injured.
over the talus. Fibular impingement on the calcaneum, sir.
So where is the main injury?
Main injury is sir
An injury.
in the subtalar joint, sir.
In the subtalar joint.
Calcaneum main injury is calcaneum and the dislocation.
Why do you say
sir.
calcaneum? Huh? Just tell me, why are you getting so fixated on the calcaneum? The
Sir,
subtalar.
on the first X-ray, sir, lateral we can see the calcaneum fracture. That's one.
What is most prominent thing you can see on this X-ray? That's what he's asking. First thing which catches your eye.
Sir,
Sorry?
the ankle dislocation, sir.
Yeah, so then why are you going to the calcaneum? In the ankle joint, what are the structures that you need to?
Okay. Webinar मध्ये Dr. John च्या. Okay. Arjun नसेल तर बघून टाक.
See in the, so you've talked about neurovascular, you've talked about fibula, you talked about syndesmosis. What else is there?
Okay.
So what is it that affords stability to ankle in addition to the bone? Can you comment on the joint space?
Yes, sir, it is decreased, sir.
If the joint is dislocated, how can you talk about joint space? What are you looking at? What distance is increased significantly?
Sorry, sir. Sorry, sir.
Yes, Avinash has also joined. So
Apart from the structures mentioned, are there any other ligaments in the ankle joint you would like to think of?
Yes, sir. Deltoid ligament, sir.
And inferior tibiofibular.
Acha, that one. Yes, sir.
Tibiofibular.
Anterior tibiofibular, posterior tibiofibular. And
So you think deltoid is likely to be injured, correct?
Yeah.
yes, sir.
So what would you like to do? Go ahead and fix the calcaneum first.
No, sir. First, we should reduce the dislocation, sir.
Okay. How will you reduce it?
Sir, in emergency or in under sedation, we reduce with traction and in the axial traction, and it is anterior dislocated, so posterior dislocated. And we have to push the heel anteriorly, and while fixing the tibia along with the traction.
Okay. I tried and tried and tried. Nothing happened. Now what should I do?
What do you see on the X-ray?
Sir, there is distance. कौन सा space होता था वो? Medial spacer is increased, sir.
Okay. Then
Plus जो space होता है, sir, that is increased. Medially dislocated.
इसके पहले वाले में क्या था? मीडियल डिस्टेंस ज्यादा था या लैटरल वाला?
Same.
पहले में भी सर ज्यादा था, सर.
Sir, anterior में जो था वो
So there's a significant increase in the medial distance. Agree. Now what should I do? What do you think could be the cause of this? Why is there a huge gap there? Any possible explanation? Any possible explanation? Anyone?
Sorry.
Can you think of any interposition?
Sir, tibialis impingement, sir, tendon impingement.
Very good. But
Impingement.
there are two tibialis, isn't it?
Yes.
Anterior and posterior. So which is likely to be interposed? Which is likely to be interposed?
The
Anterior.
So why do you say anterior?
Because displacement is anterior, so
So why will it be interposed?
So just think that the tibia has gone like this. So what will happen? The posterior will just fall into that space, isn't it? Barabar ki nahi? So the most commonly it is the tibialis posterior that is interposed. I have honestly not come across tibialis anterior interposition in ankle fracture. Or have you, John?
No.
I don't remember.
Posterior, friends.
The commonest is posterior. So let's ask somebody else. Amil
Yeah.
there?
Yes, sir.
Yes. Put on your video, yaar, sab log. Sab log chalu karo video.
Yes, sir.
Unless you are not in a position to put on the video.
नहीं sir. Okay, sir.
Okay, तो चालू करो. तो बोलो अभी क्या करोगे? You are suspecting a tibialis posterior interposition and you have a dislocation of the ankle with a displaced fracture of the fibula. Correct?
Yes, sir.
Displaced fracture fibula, which is transverse, oblique, spiral.
Yes, sir. Sir, tibialis posterior tendon is between medial malleolus and talus, sir.
No. I'm asking you about the fibula.
Yes, sir.
And you have a fibula fracture which is oblique, isn't it? Long oblique.
Yeah. Yes, sir.
Now, what will be your plan of action? She has come to me at 10 o'clock. What should I do now? Non-diabetic, otherwise absolutely no comorbidities. What should I do now?
With this dislocation, sir.
She came in like this. I tried to put her in a slab thinking that I'll be able to reduce. Lekin nahi ho raha hai.
Yes, sir.
So what should I do?
I will open it, sir.
You will open it. वो तो
Yes, sir.
बराबर है यार, क्या open करोगे? पहले क्या करोगे? What will you do? What will be the first step you will do? Let's know the plan of action. What all things you will do? Address. What will be your first incision? What is the first lesion you would like to address? And
Medially, sir.
Sorry?
Medially, I will approach
Medially
first.
you will open. And
Yes, sir. I will open and sir, I will I will put in position tibialis posterior tendon, and sir, it will come in place, and I will push it medially, laterally, and then sir, plafond will be normal, sir.
उसके पहले the deltoid ligament also is going to be torn, isn't it? With such a big space, the deltoid ligament also is going to be torn. So
Yes,
what will
sir.
you do for deltoid now? You have open medially and you have a tibialis posterior which was interposed that you have taken out. And then
Yes,
you
sir.
see a big opening there of deltoid ligament.
Yes, sir.
So what will you do?
I will not intervene. I will not intervene right now, sir.
You will not intervene right now for deltoid.
Yes, sir.
Why?
I will reduce fibula first, sir, with K wire, probably,
Okay.
and I will put it in slab, sir.
So you will put fibula, K wire in fibula, put it in slab, and then
Wait it for swelling to subside.
so you will put fibula, a K wire in fibula percutaneously.
Yes, sir.
So do you think that with a torn deltoid and a K wire in fibula, your ankle will be stable?
No, sir, it will not be stable, but
So what
I
is
will.
the... No, I totally agree with you.
Yes, sir.
You will not like to open at this stage. Agreed.
Yes, sir.
But question is, suppose you don't open at this stage, is the lesion going to be stable? Is the
No,
ankle
sir.
going to be stable?
No, sir, it will not be stable.
Barabar?
Yes,
So
sir.
क्या करोगे?
I will put a calcaneum traction like this, sir.
You'll put a calcaneal traction. Anybody else? Any other opinion?
Sir, there is huge swelling, sir, after this dislocation. So we can simply put external fixator.
You'll put an external fixator, okay?
Um,
Joint spanning fixator or fixator? Huh?
Yes, sir.
Where will you put your Sharan screws or K wires, whatever you want to put?
Calcaneum and 2 in the TBS and 1 in metatarsals.
Metatarsals. Can I give you a call in 5 minutes? Sorry, at 9 o'clock? 9 o'clock. Okay, okay. Bolo. Where all we will put pins?
2 in tibia, 1 in calcaneum and
Metatarsal. Okay. Suppose the swelling does not decrease because it
Yes,
is
sir.
still dislocated, isn't it?
Yes, sir.
So what will you do? So why do you want to reduce the medial side first and as an emergency procedure? Barabar, you said that you will reduce, take out the tendon as early as possible, correct?
Yes, sir.
Perfect. Why?
Because it is incalcinated between. It will not.
Yes, and then the skin is going to be damaged, isn't it?
Yeah, so no one's worrying about the skin. So whenever you have a dislocated ankle or foot or whatever, the thing you need to worry about is the skin breaking down, because it's usually in a position that is grossly distorted. So you need to worry about
Yes,
it. So if there is no pressure on skin, then maybe you can wait. But if there's pressure on skin, you can't leave it like that, okay? Because that skin will become necrotic in 6 hours.
So which area or which side the skin and soft tissues are likely to be damaged more?
Medial side, sir.
Medial side, correct? So you have opened the medial
Yes.
side back because you were concerned about the skin and soft tissues, correct?
Yes, sir.
Now on the lateral side, where the skin is bound to be reasonably good because it is not in tension, barabar? So why not fix the fibula?
Yes, sir.
On barabar ki nahi?
Yes,
Why
sir.
not fix the fibula? Because then that will give us stable support, correct?
Yes.
So you need to take out the interposed tissues. You need to fix the fibula. Now let us come to deltoid ligament. If you are going to do both the things at the same time, what are you going to do with your deltoid?
I will put, sir, a syndesmotic screw tape.
You will put a syndesmotic screw. Okay. Now the deltoid is all chura, na, obviously. Samjha ke nahi? It is totally bound to be torn totally. So you will put syndesmotic screw.
And sir, augmented with yes, sir. Suture anchor at medial, sir.
Manje you will repair the deltoid, am I right?
Yes, sir.
Okay. Anybody else? So you will go on the medial side first, take out the tibialis posterior, repair deltoid, and then come on the lateral side and fix it. Am I right? That is your plan? That is your plan? So this
With
is
that,
a small surgical tip. Condition like this, where there is a ligament injury with dislocation on the other side. Then what you do is take sutures through that ligament, but don't tie. Because moment you tie and you try to manipulate the outer side, then the ligament is likely to get torn, whatever you have sutured. Barabar ki nahi?
yes.
So you take sutures, don't tie them, go on the lateral side, fix the fibula, and then tie them. Same thing with coronoid fracture. When you take sutures, you take them out from here, but do not tie. Okay?
Yes, sir.
Any input, John?
Yeah, absolutely. I mean, I would. So your options is one is to fix the fibula and still put on an external fixator to stabilize the joint, and then do your repair later, or you could, if the skin is okay and the soft tissue is okay, you can think of a primary repair of the ligament.
Correct. So that is exactly what I did. Went on the medial side, took out the tendon, took sutures through the deltoid, and then did the side skip, and then did the interfrag with fibula. Now you can see the medial space reduced well, anterior space reduced well. Now what should I do? Before that, what approach should I take? What approach should I take? So in short, we have to fix the fibula. We also have to fix the calcaneum, isn't it? So what approach should I take? Should I fix the calcaneum right away?
Usually not.
Wait.
Usually not.
No, sir.
No. Why?
Because we have to put it on non-weight bearing at least 3 months, sir. So we can wait.
So why does non-weight bearing have to do with waiting?
So we can wait to, sir.
What is the reason to wait?
Let the swelling to subside, sir.
Perfect. Perfect. But then you need to plan, isn't it?
Yes, sir.
You need to plan.
We will do CT.
Anything else you notice here? Anything else you notice here? I will just trace the.
Dysmosis.
I will just trace the. I will trace the tibia. That's the fibula.
put a syndesmotic screw.
That is not.
Correct. So what will you do? Shall I go back and show you the previous X-rays? Yeah.
The type C fracture is likely to be a syndesmotic.
Yeah. Intraoperative, that how is the syndesmosis?
It was stable. It was stable. You can see there is a good overlap of tibia and fibula. But I was almost certain, I felt that this is very likely to be a syndesmotic. So I got a CT done. That's the calcaneum and that's the syndesmosis, which appears absolutely okay. That's the calcaneum.
Yes.
So now what should I do?
Is there an anterior fragment?
Sorry. There appeared to be a very small anterior fragment,
Yeah.
but the whole thing appeared very stable.
Stable. Okay. Shaput.
And it really didn't fit into that classic Shaput. So what should I do now?
So wait for the swelling to subside and then.
I waited for 17 days. The swelling went down. Now what should I do? What incision should I take? Oh, I've shown this. Sorry.
Extensile.
No, actually I took a...
You took a sinus tarsal.
The picture is not appropriate. Appropriate money. That's the
Fibula incision.
not the extensile. This is
Fibula
on
incision.
the fibula, and I just continued it as a mini whatever it is
Sinus
called.
tarsi approach. Sinus
Tarsi approach. Sinus tarsi approach. So, friends, sir said about extensile approach. Can you just tell us about the extensile approach?
Yes, so answer.
Lateral side, sir, at the junction of skin and
Yeah, he is not audible. Yes, Amil.
You started very well at the junction of something very, very important
yes,
words.
sir, I forget.
Anyone would like to continue his statement? He said junction of.
Junction of what? Amil? He also has. Unmute yourself. Yeah, not yet.
Hello.
Yes, yes.
Apollo.
Tell now.
Yes, sir. Sir, skin between dorsum and plantar, sir. We will take incision.
Perfect. Very good. How can you make out?
Then skin color, sir.
Yes, perfect. Very nice. So this is, as sir said, this is a sinus tarsi approach. How does it differ from the extensile approach?
This is a small incision, sir.
Yes.
What level?
Landmark.
Just below the lateral malleus.
Here.
Below and one landmark you told, the tip of the lateral malleus just below an anterior. Another landmark where the incision will go.
Sir,
Direction.
Anteriorly at the fourth.
Very nice.
Yes.
Can you just complete your sentence? Fourth what?
Fourth what?
Left,
Deduction of fourth ray, sir.
Fourth.
Base of fourth method.
Perfect. Very good. Very good. Then what do you do? Do you approach the sinus trachea directly or do you come across something?
will come across a flexor digitorum.
अभी क्या है ना फ्लेक्सर डिजिटोरम इधर आएगा क्या?
फ्लेक्सर डिजिटोरम कहाँ पे आएगा?
Flexor नहीं sir, sorry sir.
What tendon do you come across when you do your sinus tarsi approach?
Peroneal.
So,
Sir, peroneus, sorry sir. Peroneus brevis, sir.
just brevis.
Peroneus longus, sorry sir. Peroneus longus, sorry sir.
कुछ बोल दो.
Peroneus longus, sir.
You get one tendon or two there?
Two, sir. Sir, peroneus longus is bit posterior to peroneus brevis.
So, which one will you get there?
Longus.
Get both the cross. What
Not
about
seen.
this? Where's peroneus tertius? The three peroneal, na?
Yes, sir. Not peroneal tertiary is not here. It's a bit.
Where is it? That's part of the extensor muscles, huh? It's anterior.
Everters.
It's anterior to the fibula, huh?
Plantar flexor and everter.
Yeah. Plantar flexor.
Peroneus, sir.
Which peroneus? Tertius goes anterior to the fibula, huh?
This peroneus tertius is a part of anterior compartment.
Yeah.
Though it is a peroneal, so it is a dorsiflexor and everter because it is a lateral, bit laterally.
So when we are
So
writing
here
an
you
approach,
will
yeah. One more thing, danger. What is the risk here? When you are writing any approach, if it is comes as a question, then what danger you write in this?
The structure.
Facial peroneal nerves.
Peroneal nerve.
Lateral side, ankle joint.
About that.
Sural nerve.
Yeah.
correct. Correct. So here you will have two muscles, two sheaths which you just retract, and there is a muscle which goes there. There is a muscle which you need to reflect.
Yeah.
To see the sinus tarsi, you reflect the muscle. Fleshy thing. Fleshy thing. Can you see this?
Oops.
That's a muscle I've split. Can you see this muscle?
Yes, sir.
So it is on the dorsum of the foot, correct?
Yes, sir.
It is starting here, correct? It is attached to the dorsum. And the direction looks like this. Can you see my cursor?
Yes.
So what do you think there?
Barabar?
Sorry?
Likely to be.
Abductor.
What is it likely to be?
Cancer digitorum.
Extensor digitorum. उसके आगे
Abductor digitimin.
Abductor digitimin में किधर आएगा रे बेटा? So this is extensor digitorum brevis, correct? Yes. So I would like to know two things. What is this and what is this? Can you see my
space is, yes, sir. The space is first seen is subtalar joint, sir.
yes, also
And
called from
the
this side,
second,
what is it called?
and calcaneum tuberosity, sir.
Kidhar?
Sir, the second is second time when you person put the inferior retractor posteriorly, sir, there.
No. What I want to know is this. What is this? And why?
Sir,
For virus correction, sir.
हाँ sir.
Correct the virus.
Sorry?
Traction and virus.
Action.
This,
Correct.
yes, sir.
Traction and virus. Correct? Virus valgus correction.
Yes, sir.
Perfect. So what is it called? What is it called? What is this apparatus called? Okay, you can see a part of it and you can see this also, no?
Is that
बराबर कि
traction?
नहीं?
Oh,
Sir, bowler strip लगाए.
yeah. Great.
Correct. Very good. Okay, now what should I do?
Sir, yes.
This is a traction view. Correct? Now what do I have to do?
Sir, fix the calcaneum fracture around this sustentacular talus, sir, by fixing the posterior facet and tibial. If articular joint is maintained, then we can fix tibial tuberosity by
Okay.
two.
So use this annotation and show us the posterior facet.
Sir,
You know what is annotation?
annotation जो दिख रहा.
So either go up and a window will appear.
View options में.
इसमें there will be annotate. Take that and use the pen there and show us the posterior facet.
Anyone got that? You can see some pen mark anywhere.
Yes, sir, I can see, sir.
Just click over that.
Oh, shit.
Yes.
Yes, very good. Now where is the facet?
हाँ सर.
कुछ कुछ बन रहा है.
सर वो बड़ा नहीं हो रहा है सर.
कोई नहीं, उसी से करो ना उतना सही.
बड़ा हो जा रहा है सर.
So try and draw the facet.
Yes.
So is this a tongue fracture?
Sir,
Is this
more
a
likely
tongue fracture?
depressed.
Very good. Very good. Who has drawn this? Very well drawn. Very nice.
Subhanshu.
नहीं, मैं I
Very
didn't
good.
draw sir.
Acha.
Maybe Vikas, you did it yourself.
And then I didn't do it. I didn't do it. Somebody from the student side has done it. Very good. iPhone.
iPhone.
Very good. Very good. So that's the posterior facet, which we need to lift up. Correct?
Yes.
Can you see the fragment that has gone down? Can you see the fragment again? Is that the fragment that has gone down? Correct. Very nice. Very nice. Which we have to lift up, isn't it?
Yes, sir.
So, and
This one.
somebody said that this is a joint depression fracture, correct?
Yes, sir.
Whatever. Very good. So you need to lift up this. Correct? So, yeah, you'll have to take that off. Otherwise, I cannot go further. Use an eraser. Use an eraser and take that off. So first we fix the tuberosity to the body, and then here you can see the osteotome, correct?
Yes, sir.
Can you see the osteotome here? Now the posterior facet is lifted up, right? Ye dekho. Kaya? We are done.
So, it's
Okay.
9. Sir.
Yeah, 9 o'clock. Okay, okay. Next time. Next time.
So I think after 2 weeks we can.
What happened?
Chalega. Chalega. After 2 weeks. What I will do, Janki, is
Yes,
send
sir.
you this case so that you can share with them. So we don't
Yes.
have to go back and discuss this case.
Okay, sir.
I'll send you the presentation.
Okay, sir.
We are almost done. I'll send that presentation.
Yes. So thank you very
Okay.
much.
Thank you, sir.
Chalo. Bye-bye. Bye,
Thank you, sir.
everybody.
Thank you very much, sir. It's great.
Bye,
sir.
bye, bye. Chalo. Bye,
Thank
John.
you, sir.
Thank
sir.
you. Thank you.
Thank you, sir.
See you on next Thursday. Sorry,
Yes, thank
you, sir.
next.
Tuesday, sir. Thank you, sir.
You think I should go a little fast?
सर एक्चुअली शुरू में थोड़ा डिले हो गया शुरू करने में, इस कारण से, नहीं तो टाइम तो अच्छा, ये बिल्कुल टाइम पे चल रहा था सर.
Okay. क्योंकि basically I wanted interactive session rather than just giving a talk.
नहीं, मैं अगली बार क्या करूंगा सर, 15 मिनट पहले ओपन करके बैठ जाऊंगा ताकि सब लोग ज्वाइन करके.
Okay, okay.
इस बार मुझे थोड़ा सा टाइम मैं एडजस्ट नहीं कर पाया सर.
No issues, no issues.
मैं अभी
Okay, chalo, bye bye.
थैंक यू सर.
Bye.
थैंक यू वेरी मच.